Okay, ma'am. So if there are no questions, may I call on Virupaksha Biswas from Kapdweep Super Specialty Hospital in India um, to deliver their presentation.
Yes, am I audible? Hello?
Yes, sir.
Hello?
You are audible.
All right. I'm gonna share my screen now, right?
Yes, please.
Can I see my screen?
Um,
Yeah,
there is
just right. Just a minute. So can you see my screen?
yes, sir. We can see your desktop.
Right. There we go. So should I start?
Oh, we can see your PowerPoint presentation, sir.
Right. Yeah. So should I start?
Uh, yes, we can see the presentation.
It's all about so I'm sorry. It's all about IEM, inborn errors of metabolism. Let me just straightforward go since there's a time constant of 20 minutes. Finish it off. So why does this matter? At the end of the day, IEM, inborn errors of metabolism, let me tell you, at this point of time, they present at around in a very younger age, predominantly, and then they go forward, and they can also present in the geriatric population as well. So this is one of the very big hallmarks of this inborn errors of metabolism. Now you can see this is just in one word, in one sentence. If I complete, it is metabolism never fails politely. It's a problem about with the enzyme. It can be a cofactor. It can be a structural configuration of the enzyme. It can be anything. So it's the problem with the enzyme in itself which will provide the essentials for the body. This is why the topic becomes very important. Let's talk about the clinical consequences. What happens usually? Usually, these cohort of patients, they usually come with neurological consequences, neurological ailments. One of them being seizures. I've made a background of that just for presenting it properly. They usually come with seizures. They have GI problems. They have cardiac problems. They also do have muscular injury, and end of the day, they have a failure to thrive. This is the biggest part of it. So whatever I found out, it's from my 13 studies. I will delineate one by one at a certain point of time, and this is what it is. Time matters more than technology. This is very important. We need to find this. We need to find the culprit ASAP as soon as possible, and that will lead to a better prognosis, I believe. So this is what happens. Let's talk about the historical background. You see, I've given the picture there. It's I've not taken his study. That's the paradox of the irony. But I've given his picture there. It's Archibald Garrod. This is the person who at first linked this disease with the genotype of the patient. So this was a novel study done a long time back, 100 years from now on. So this is how it happens. Now, definitions. See, these are monogenic disorders. These usually happen in one part of a gene which codes for a particular protein. Like for, I believe for PK, it's phenylalanine hydroxylase. So it's something like that. It's a monogenic disorder. And now you can see 1,500 distinct conditions are identified, almost 1,500 conditions, distinct conditions, different conditions are identified, depending on the genotype. I'm saying it about the genotype. Let me draw an analogy. In this case, It's like the FAB classification for AML has been abandoned. Now we have a new classification depends totally on genes. So now, depending on the genotype, there are 1,500 different cases of inborn errors of metabolism. Can you just imagine? This is what happens. Let me go to the next slide. It's global epidemiology. I'm talking about UK and USA. And in the UK, you have, you have almost out of 2,200, I believe. Not 200. It's out of 700. You are having one person with the problem of the ailment, and in the US, you have 1 out of 2,200. Still, it makes a very good number. If I come to India, since I am from India, it's absolutely bizarre out here. So why do we miss the diagnosis? It's because of DD. Let me place it in this way. It's because of this differential diagnosis. That's why we do miss the diagnostic part. Patients usually present with sepsis. Sepsis will of course lead to hypoxia or hypoxic injuries, and with multi-organ dysfunction syndrome or a multi-organ failure. So in that case, yes, of course, this is why we generally miss the diagnosis. In many cases for babies, we have kwashiorkor and marasmus. So in that case, there is an overlap, right? Overlap of the symptomology, general symptomology of the patient. So in these cases, we usually miss. So this is why I have given the caption: the disease has many disguises. The next one. So what are the red flags? Well, I have said I've placed a very awkward picture out there of a person vomiting. Of course, the patient will vomit. The patient will be extremely lethargic, will have seizures, will have metabolic acidosis, of course, due to hyperammonemia, and also due to lactic acid accumulation. These are the red flags that are going to happen. You can see it from the slide itself. The next one. So where is the role of clinical pathology? So in this case, plasma amino acids are identified by amine. You can simply you draw the blood of a patient and measure the amount of the amino acids. That's it. You have gas chromatography, mass spectrometry, but I'll be speaking beyond them as well. You have got a blood smear blood smear or a bone marrow smear, where you're going to have lymphocytes. You're going to have not lymphocytes. In fact, you're going to have you're going to have lymphocytes with vacuoles out there. I got a case, I believe, of this lysosomal storage disease. I believe it was Niemann-Pick disease, I believe. So in that case, I had taken a picture. You can just have a look at the picture. This is one of the macrophages which are filled with vacuoles at the center. I'm just pointing it out. This is the case. This is the one. This is the total macrophage, and there you can see that it's filled up with vacuoles. It's a very classical picture. I got it in I zoomed it, and I got it via digital pathology. It's a software out there, which is connected to my microscope. It was probably I believe it was Niemann-Pick, I believe. I don't remember exactly, but then I got the picture. Let's go for the next. So in case of neonatal screening, of course, mass spectrometry, they can screen very well, and the sensitivity is almost equivalent to 98%. Now, there is something about this mass spectrometry thing, tandem mass spectrometry. See, mass spectrometry, I don't know how many of you know the principles, but let me just say a bit about this. In one short example, I can tell you, it's like a box. Suppose you get an unidentified box. What you do is that once you get the box, you break the box. You break the box, find out the contents in it, and of course, if the box is locked, you have to take it in the. Forget about the box. Let me refine it slightly a bit more properly. You take a attaché. So there are locks out there. You break it, and after that, you're going to get parts in it. You're going to get some equipments in it. And once you get those equipments, and once you measure them, and once you see them, you will understand that this is from this person. You'll get to know if that person is your acquaintance, or if you go for go for a search what us if you just hand it over to the police and the police goes and searches for it. So we actually get to know where the problem is with tandem mass spectrometry. This is basically the principle of this particular part of TMS. But in that case, I have to simplify the entire thing via saying this. Well, the next slide. So what will be the impact of screening? Of course, mortality shall reduce. We shall find out the disease faster. And at the same time, of course, it has to be cost effective. So of course, early detection will save future. I have placed photographs of babies because we usually find such patients in the pediatric cohort. Right. So this is the case actually. So next one. So this is how I've designed the review. It was I had picked up from the NLM catalog, the NLM library, PubMed Central, and what should I say? And it was Scopus, I believe Scopus. I chose these three platforms. Yes, there's a bias that I have left out other this thing. I've left out the others databases. It was slightly of a bias, and it was a systematic review and not a this thing, not a meta-analysis. Because in meta-analysis we take very rare cases, cases which are very rare actually. So at the end of the day, I'm not in favor of meta-analysis. This can be a bias from my end, but let's just move forward and see. These are the studies. You can. I will not go into the detail due to time constraints, but these are the studies that were taken right from 1908. Garrod, I have taken it. In fact, right, I have taken it. So what did he introduce? He introduced chemical individuality and genetic basis of metabolic disease. This was the first study that I've taken. It's still there, the internet. And once this meeting will be over, anybody who would like to get an access can just mail me in my email ID. I'm going to send the presentation. They're going to see this studies, and I'm going to send them as well. I also have published this in Journal of Pediatric Surgery. It's one of the better journals ones, I believe. So yeah, I'm going to send the paper as well. So this were the studies that were taken, right, till 2019. Okay. So this is one of the problems that I found out while I was going through the studies. Studies were heterogeneous. They were not same. It was slightly different, I believe. Everything didn't match up. It was not 1 + 1 = 2. This was one problem due to wide variation in methodology and diagnostics. And then, of course, it depends on the demographics of the country as well. It depends on the genotype of a particular individual from a different country. Of course, we have Caucasians, we have Africans, not Africans, we have Asians. We have a diverse set of population. This is the problem. And this is why people generally, it is very difficult to come to a proper conclusion when it comes to epidemiology and things like that. Something of this sort, epidemiology, and what could be the final endpoint. Because we doctors always try to go for a final endpoint to anything, to any damn thing. We try to do it. So when it comes to leukemia, yes, in the same time, we try to go for precision diagnostics. That I'll talk about later on. For this IEM as well, we try a lot. But at the end of the day, this is the problem this is where we get hindered. The next one, molecular diagnostics. Well, NGS, next generation sequencing, that's the machine, right? So I know how to operate this machine. It's very easy actually. I would, if somebody mails me, I would give them a presentation. I have a video of mine. I can send it in Google Drive. Anyways, so this is not important. What is important is NGS will actually find out and actually will give you the lead, or almost it is very sensitive, very specific, and is going to give you the lead to the problem, the exact gene which is causing all this Hara and Kiri. That is the part. So NGS is a very powerful tool, and in India is very much available. I am from West Bengal, and in West Bengal also it's very much available, very much into the picture. This next generation sequencing. That's one of the part. It can take up the whole exome. It usually takes up the whole exome, and then resolves the complex phenotypes and stuff like that. I've just put it in the slide, but NGS is a very good tool. It can be used, and it's quite affordable as well. Well, the next one. Yes, of course, it will require, I have written out here that it requires expert genomic interpretation. But let me tell you, I have not put it on this slide due to time constraints, but actually decrypting Decrypting an NGS report is not that difficult. It is just not difficult. There are a set of genes you'll get to know, and once you get to know the set of genes, you have the targeted treatment for those, at least for cancers and for also for IEM and also for all other metabolic complications, because time and tide waits for none, and time changes, right? So this is how it is. So yes, of course, multidisciplinary collaboration. Of course, you need that. The Indian context, you can see it. Let me not talk about the first part, consanguinity. I will not talk about this. There's a reason for that. But then, yes, there's a higher prevalence. It's because there is a section where there are marriages within the family as well. So let me not just talk about it. But then there's limited screening infrastructure. There's delayed diagnosis. This is a big problem. The third one is the bigger problem in the Indian context. It's delayed diagnosis. This is the one. Right. So, all right. The next one. Oh, right. So its mortality exceeds 50% in severe forms. Survivors often have permanent neurological. They will have, of course, permanent neuro deficits, and they might also have a failure to thrive, and they might have many other problems. Let's not go into all those. Yes, of course. Let us not, God forbid, let's not talk about the end of this thing. It's quite obvious that if a person or a baby fails to thrive, or a person fails to thrive due to IEM, what can happen? Let's not talk about that. This is important, the therapeutic evolution. Yes, what I have focused on this particular presentation is precision medicine. Precision. I will talk about it. That is why I was skipping through the slides. There you go. Number one. This is a very standard one. ERT, enzyme replacement therapy. Like, for example, in Gaucher disease, we have glucocerebrosidase. We have that enzyme that is deficient. So we're going to put the enzyme. Anyway, you can see it. I've just given a photograph. But at the same time, yes, there is a barrier to the cost. It's quite costly and stuff. And in my study, or in my research, when I was going through, I found that it was quite effective in lysosomal storage disorders, in LSDs. That's how things are. That's what I found out in my research. So I've just put it out there. There can be a bias, but then I've just put it out there. Substrate reduction therapy. Now, this is pretty interesting. Let me once again take. Why do you use it? You use it in Gaucher type 1. You use it in Niemann-Pick C. We use it in late onset Tay-Sachs disease. And this is where, let me take the example of Gaucher once again. So there, what we were doing, we were providing the enzyme glucocerebrosidase. Here we have an enzyme which increases the toxic metabolites. So what we do is that we hinder that enzyme. We hinder that particular enzyme, which will increase the toxicities for any disease. Let me just generalize the entire one. We will hinder that particular enzyme. Like in this case, in ERT, we are going to give the enzyme which is deficient due to genomic instabilities and stuff. In substrate reduction, the general fact being, we're going to hinder that enzyme which gives rise to toxic metabolites. That's the part. That's the catch. And once we start doing that, we stop that particular enzyme which increases the toxic metabolites. We will have some percentage of the good enzyme which are going to give us benefits. This is where SRT comes into play. I've given a cap out there. Less toxin means less trouble. I've given a caption. Well, next one. Chaperone. Now, chaperone therapy. Now, chaperone therapy, you should remember it by fold, hold, or disengage. That's it. Fold. What is this fold concept? Foldases. What does foldases do? This is, of course, artificially engineered. What foldases do? they fold the protein properly. If a protein is misfolded due to some genetic instability, they fold the protein properly. What about hold disease? If a protein, or if of course enzyme is the smallest fragment of an enzyme is a protein. So in that case, in hold disease, if the protein is misfolded, they're going to hold it. They're going to stop it. They're going to hinder it to misfold. So of course, it's not going to misbehave. And for disengage, that's last part. That if everything has gone wrong, they're going to disengage and destroy that particular enzyme, which will be the main culprit. This is the chaperone concept. And that is why I've given a, clincher. Sometimes enzymes just need some support. Still, this treatment is very expensive. That's the problem. Of course, now if I come to the main part, viral vector mediated gene delivery. These are the things which are into study now. They are into, say, phase 1 or phase 2 study problem. These are high-end parts. Say, suppose in case of cancers, you have CART, CERT therapies. These are evolving with every passing day and with an extensive amount of research, right? So this will of course go for they are of course aiming for definitive curative options for patients with IEM apart from ERT or SRT. So this is one of the part, and of course this is still under investigation. Many studies or many portions have crossed, as far as I remember. They have crossed phase 3 as well. They're just about to be placed into phase 4. But still, at the end of the day, I must say that yes, these things are very costly. They're pretty costly. It's not that they're very easy. At the same time, when I say about detection, what is the next one? It's a titling cofactor. Let me speak about detection. Detection will, of course, at one point of time involve AI, artificial intelligence, in which what I prefer is the random forest model. That's one of the most evolving and one of the most powerful models, where there are signals and one signal cuts out each other. They vote. That if you can imagine, if there are 8 signals, I'm talking about AI now. If there are 8 signals, the 8 signals are gonna pick and choose the best one in between themselves. That is how it happens. That is how the entire thing is being programmed. So this is how it is, and of course, it's going to add to precision medicine. The next slide, of course, dietary and cofactors are of course there for best results. That we'll have to either add on diet or have to cut on diet. That's something that is very much into IEM, into preventing IEM. Of course, that is there, but this is a very small portion of it. Cofactor therapy is, of course, there. It accentuates enzyme, but this is just an adjunct. That's what I might call it. The next one is early diagnosis, of course, is the strongest predictor of outcome. Integrated biochemical and genetic diagnosis are essential. Genetic. This is very important. So I was speaking about NGS. I didn't speak about spatial genomics today, but yes, we should go for future. We should go for this high-end genomic studies to identify the exact problem with the patient person. So this becomes of paramount importance about the genes and all, because genes are ultimately, you see, in case of pregnancy, we go for a karyotyping for both the father and the mother. Why do you do it? We go for the karyotyping is nothing but chromosomal analysis, right? And at the end of the day, we are going into the depth of it. And yes, even that is going to help. And there are many other methods like FISH, fish fluorescent in situ hybridization. That's how we call it. There are plenty of things. There is lipid biopsy for circulating DNA. So we need to focus and think which is suitable and which is feasible economically. That is a big part, right? So this is it. Advanced diagnosis, if you are unevenly distributed, of course, I was talking about it all the time. This is a diseases. That's why even this line actually. This is a global care. It's not. It's not. And I have not given the next part of it. There are policy gaps that exist because of different governments, different places and stuff. So this is the global inequity, and this is the problem. So what is the limitation? The limitation of uh, my study. It was of course heterogeneity. It has to be heterogeneous at the end of the day. There was an overrepresentation, of course, of high economic income country data. Because as I said, I picked a maximum of the studies from the NLM catalog, the NLM library. Uh, of course, somewhere from the somewhere Indian studies as well. The 70, 80, 19 studies I do were from Indian studies. So even there, I found a problem, and evidence is always evolving. So let's wait and watch where these things go. So this is one of future directions. Universal newborn screening. Universal newborn screening. This is one part where I'd like to focus on that every newborn should be screened. This is one of the other things, and population specific genomic databases should be there. It should be stored and should be analyzed properly, and then a proper conclusion can be drawn, a proper inference can be drawn, right? So this is one of it, and there must be an affordable access to therapy. I was speaking about it all through the lecture. So of course, we will need multidisciplinary care for this. Early recognition, equity, and metabolism. Forgives early but never forgets to delay. That's how it goes. Okay, I believe did I reach to the end? Yeah, I did reach, and this is how this is me, Dr. Biswas, presently fellow, NHS RCP, critical care, and I'm a
Uh-uh.
clinical and interventional pathologist. And yes, with pleasure. And I would like to thank SCIENTEX conferences for doing this opportunity. Thank you.
Thank you, Dr. Bidwas, for your excellent
Ma'am, thank you so
presentation.
much. Q&A, please.
Yes.
Q.
If anyone has questions for the speaker, please feel free to ask now.